Hi, everyone, and welcome to our program, which is focused on optimizing your quality of life and how to manage side effects in Hodgkin lymphoma care. My name is Stephanie Trong. If we haven't met before, I'm the founder of The Patient Story. More importantly, I also got a blood cancer diagnosis that was a few years ago, though mine was in non-Hodgkin lymphoma. I believe, though, that we have so many shared experiences, including how to deal with side effects and what can we do to help holistically with things like pain or chemo brain, which I feel like I still have, and what are the long-term effects to that point in Hodgkin lymphoma. So these are some of the areas that we'll be discussing today. And it is overall what we try to focus on with in-depth conversations here at The Patient Story. We try to help navigate patients and care partners, everyone in the support circle after a cancer diagnosis, which we know is a very difficult time. And we do this primarily through these in-depth conversations with patients, care partners, and top cancer specialists like the ones you'll hear from today. We are so proud to be partnering with our friends at the Leukemia and Lymphoma Society, or the LLS, and with Immerman Angels for this program. The LLS is the oldest running nonprofit dedicated to finding a cure for and funding research for blood cancers. They have amazing resources like their information specialists who help you with your questions one-on-one. They're just one phone call away. Also, the Clinical Trial Support Center, or CTSC, has clinical trial nurses ready to help you as well, one-to-one support, because we know that clinical trial space can be very daunting. Also partnering with us for this program is Immerman Angels, another great advocacy organization. Immerman Angels specializes in connecting people for peer-to-peer support, and this is across cancer, so not only in blood cancers. I actually used Immerman when I was going through my chemotherapy and then signed up to be an angel or support provider after because of that experience. So we also want to give special thanks to Pfizer for supporting our educational program. Pfizer's support really helps programs like this. We make it more available. It's always free for our audience. We do want to note that The Patient Story, the LLS, and Immerman Angels retain full editorial control of this entire program. On that note, also a really quick reminder, an important one, that this is not meant to be a substitute for medical advice. And right before we get to our program, what's also really important is we want to hear from you. We take what you tell us in terms of feedback very seriously. Things like whether this program was helpful, what topics you'd like for us to cover in the future. So please fill out our survey that will come to you when this program ends, and it should just take a couple of minutes. Okay. Housekeeping is done. Now to introduce tonight's patient moderator to help us lead this conversation, Dr. Sam Siegel. Dr. Siegel, whom I now call Sam as a friend, very grateful to know you that way, has become a patient advocate after her own experience with Hodgkin lymphoma, going through multiple lines of treatment. So, Sam, please take it away.
Hi, my name is Sam Siegel, relapsed refractory Hodgkin's thriver, mom of three, loving wife, primary care doctor, and I'm here tonight to talk about Hodgkin's lymphoma, the latest treatments focusing on reduced side effects and holistic approach to care. I have the privilege of being here today with Dr. Andrew Evens, who is a specialist in Hodgkin's lymphoma at Rutgers, leading clinical trials for more than 20 years, and also the medical director of RWJ Barnabas Health. Hi, Dr. Evans. Can you tell us more about your path into lymphoma treatment and all of the amazing things that you do for the lymphoma community?
Dr. Sam, thank you so much. It's really thank you to you and everyone else for the invitation to have this really important conversation. In terms of my path, I think like many paths start, it's where you trained. And I completed my fellowship at Northwestern in the Robert H. Schullery Comprehensive Cancer Center in Chicago. And when I was going through my fellowship, I was just fortunate to be exposed to some incredible Hodgkin lymphoma mentors, really lymphoma mentors, non Hodgkin's and Hodgkin. One in particular, Dr. Leo Gordon, who was and is still the director of the lymphoma program, is Dr. Jane Winter. Also, there, she's one of our recent ASH presidents for our big national society, and many others, Dr. Marty Tallman, Dr. Steve Rosen, just really stalwarts in the field of hematologic malignancies. And I had that early interest. Now, this is over 20 years ago. I don't want to date myself too much. And at the time, we even knew 20 years ago Hodgkin lymphoma was pretty curable. In fact, we've known that since the 1980s. And what your case elucidated there is really yes, it's curable, but nothing's 100%. And sometimes it doesn't always work, or sometimes there's side effects. And so, even though we have known for a few decades it's very treatable and curable, we're always trying to do better. Number one. And number two, do so with more tolerable targeted treatments, so called immunotherapy or targeted treatments. So, it's just an active area of study. And the last item I'll mention, just in terms of pathway and journey, is I was exposed at that younger age, finishing my training, to a global network of Hodgkin lymphoma experts. There are many different meetings and conferences we all go to. There's one in particular, believe it or not, in Germany, Cologne, Germany, right along the Rhine River, that they've had for over 20 years. They've really been amongst the world's leaders in Hodgkin lymphoma research, clinical research, basic science research. At the time, every 3 years, all of the Hodgkin lymphoma experts across the world meet there. Now it's every 2 years. And when I say all of the experts, not just the clinicians, it's soup to nuts Hodgkin lymphoma. It's epidemiology, what causes it? It's etiology, what's in the microbiology and genomics. It's, of course, diagnosis, it's treatment. It's also, importantly, post treatment about survivorship. And just really an incredible meeting. And when I went to that first meeting as a young whippersnapper hematology oncology fellow, um, I knew that was for me. Something called to me about it, and knowing that it so many different aspects related to Hodgkin lymphoma. And I've just been really fortunate to be involved in the field for over 20 years now.
That's super exciting to me because just like you said, the path that kind of leads us there, the things that we're exposed to, that resonates with me a lot. I did a lot of hemonc in my internal medicine residency. Started off as a hospitalist where I did a lot of hematology, oncology, and sort of had that lens always with really end stage pathology, with people coming into the hospital being very sick, and then going to outpatient medicine and seeing people sooner and trying to get them diagnosed sooner. And then I got cancer. And my story began almost 3 years ago now when I began feeling super exhausted. I thought I was just tired like every other doctor parent was tired in the pandemic. Had a lot of justifications for why I was feeling that way. Um, Virtual care, just sort of the change in care delivery throughout the pandemic. Being a doctor mom, a lot of people I knew were tired. Then I was coughing, but there were some wildfires in California, so I thought maybe that was it. Maybe I'm getting asthma. And then when I developed a rapidly growing, rock solid, painless lump above my collarbone, I thought, oh gosh, I have cancer. So once that showed up, I was kind of no longer in denial, and got a whole series of tests that ultimately led to a diagnosis of stage 2 AE Hodgkin's. And I ended up getting it was a shock. It was a complete shock. I like to say I was a marathon running doctor mom. I was felt like I was just minding my own business, doing life, and then boom, Hodgkin's diagnosis. And I started off treatment super, what I believe to be healthy, even though I was feeling symptomatic. And I started what is, or at least back then, it was considered the standard upfront, called ABVD chemotherapy. I'm sure you know all about that. And then I developed, my cough went away with my initial chemotherapy, and then after about 2 months, a cough came back. And around that time, I had had a scan that showed that my disease was responding really well. And so we decided to drop the bleomycin at that time because we thought maybe I was developing a new cough after the cough had gone away and I was getting a bleomycin related cough. So then I continued the next 4 months with AVD. Um, and and at the end of 6 months, I got a scan, no evidence of disease, and that was very exciting, but also troubling because I felt really, really bad. And I wasn't sure, do I just feel bad because this is how a body feels after you've had that much treatment, multiple drug regimen for 6 months, or is there something else going on? And then, within a month, I was diagnosed. I had another PET scan after developing symptoms of a relapse, and I had a PET scan that showed that I had developed a most likely a relapse, and then had to go on and get various procedures to get tissue to confirm that relapse. So what started off as seemingly a simple cancer, or winning the cancer lottery, as some people are told, I realized very quickly that the treatments are hard, especially some of the older treatments before you get to the immunotherapy and the newer discoveries. And even if you get cured or no evidence of disease, it can come at a great cost. Allopathic Western medicine saved my life, but it also really decimated my health at various points. And so I realized we need other tools. We need to embrace this other field of medicine to complement that, and to help people withstand the toxicity of treatment and then recover and rehab from it when they're done. So I'd love to hear what you have, your thoughts on that.
In the bigger picture, the global picture, I realized a number of years ago, as many others do, is there's so many good clinical trials happening across the world. But every clinical trial asks a slightly different question. And at the end of the day, whatever that good clinical trial is, how is that applied at the bedside? And sometimes, for better for worse, a little bit of both, treatment ideations and recommendations end up becoming one size fits all. And we know every patient is different. I always say, yes, there's a lot of commonalities in Hodgkin lymphoma or non-Hodgkin lymphoma, but every patient's a snowflake, unique and different. And how do we take this large amounts of data, amalgamate it, and apply it to the patient? So-called individual therapy or personalized therapy. And it's difficult because we have lots of data, and there are like lists of recommendations, you find certain guidelines. But what about you, Dr. Sam, individual patient with your stage, your albumin, your lymphocyte count, knowing that there might not be one best therapy. There might be treatment option A, B, or C, but is there data or algorithms that I can put my characteristics, my desires, my hopes, and patient preferences to say, if I go with A, B, or C, here's what I would expect in acute within 1 or 2 years, and here's what I would expect moreover 30 years down the road. So we can talk more about it. We were really excited to set up a consortium by the acronym HOLISTIC, Hodgkin Lymphoma um, International Study, ST, for individual care. And it's one that we've just been really fortunate to get truly global participation and collaboration.
That is very exciting to me. That's very exciting because my mindset really shifted, and this is kind of leading to our next topic. But my mindset really shifted from the beginning, where it was like, oh, stage two, and I was I'm a young mom. I have my whole life ahead of me. I was so afraid of dying. I'm like, let's hit it hard. Let's do everything. Let's get the strongest therapy. And then as I began to move through treatment and experience, for me, what were some pretty devastating adverse effects that I wasn't sure how long they would last. Um, and primarily as a doctor, for me, that was the cognitive impairment. I experienced severe chemo related cognitive impairment, which is like the worst form of chemo brain. So and then I gained 40 pounds from steroids and became severely metabolically ill. I mean, I got the rash that people get when they are going to develop diabetes called acanthosis nigricans. And my glucose was really high, and my cravings had changed. And I just wasn't sure that life as I knew it would ever return. So then when I developed symptoms of a relapse, my mindset was different. Even just 1 month later, it was like, well, maybe let's not give it everything, throw the whole kitchen sink at what I've got here. Maybe let's sort of make some decisions about how do I take the least amount of therapy to get me into remission and get to transplant. And right around that time, the science had shown that people were doing single agent Brentuximab as a bridge to transplant. And if it didn't work, then you could go on and get ICE and some of the other stronger therapies. But there was science to support that was a reasonable thing to do and a lesser toxicity than some of the old bridge therapies to transplant. And I was so grateful because I could not psychologically, mentally, physically handle the more traditional like cytotoxic chemotherapies that I had up front and that were previously used as part of salvage regimens. Um, so I did that. I took Brentuximab. I initially took the exact dosing that was used in the trials, and then I developed some sort of really strange, almost like a rheumatoid arthritis type illness, where like really bad morning stiffness and joint swelling and pains and these crazy rashes, and it got better with dose reduction. So that was also really, we're starting to talk about individualizing the therapy for the person, for their circumstances, for their maybe medical comorbid conditions that they have, and make decisions that way. So, yeah.
It is, and it sounds like you had a tough time, and that's where everyone is so different. There's some patients who no one flies through chemotherapy but do relatively well, and then there's you just weird side effects that pop up, and I think you kind of went through that roller coaster, and it sounds like we're able to course correct where needed with the dosing. But you brought up brentuximab vedotin, and we're happy to say there have been two big therapeutic breakthroughs in the last 10 years for Hodgkin lymphoma in particular. That's one. It's an antibody drug conjugate that we figured out over 20 years ago. One of the antigens that sticks out of a Hodgkin lymphoma cell called CD30. So this is an antibody that attaches, has a little bit of chemotherapy attached to it, and then it internalizes. So it's still chemotherapy, but it's a little more targeted. It gets inside the Hodgkin lymphoma cell. And then after that, that was over 10 years ago that was first approved. And then after that are these checkpoint inhibitors, or so-called immunotherapy, that aren't just approved for Hodgkin lymphoma. They're approved for more than 12 different cancers: melanoma, lung cancer, renal cancer, etc. And it's fascinating science, and it's in a way the antithesis to chemotherapy, because how does chemotherapy work? It just kills cells that grow fast. Not very specific in the body. Obviously you hope it knocks out lymphoma cells, and side effects in our body is anything that grows fast. So what's one of our fastest growing cells? The hair, the immune system. So not so targeted, but we still use it. So it's something obviously we do, but it's now the whole future, current and future are more targeted medicine. So how do checkpoint inhibitors work? Is it basically reinvigorates the patient's own immune system, in particular the T cells. And in a simplistic way, there are some cancers like Hodgkin lymphoma that basically have receptors that don't allow the patient's own immune system to engage with the Hodgkin lymphoma cell. It's almost like creating a force field. And what these inhibitors do in a simplistic way is it takes down the force field and just lets the patient's own immune system go after and take down the lymphoma. So we've learned really how to use these medications when it comes back or relapses, but really in an exciting way now for newly diagnosed patients as well through clinical trials.
Yeah, it's crazy. I'm so excited, and it hurts a little bit just because I know that there was like very little progress, and I mean, in terms of the regimens changing over 40, 50 years, and then within the last 5, 10 years things have changed so much, which is super exciting. But also, like, for someone like me, if I was diagnosed with my exact same clinical situation as I was diagnosed back in 2021, my treatment might be different now. So that's pretty crazy to think about, because for so many decades it was kind of the same ABVD and maybe radiation. And yeah, where does radiation fit in all this? I haven't even heard much about radiation
Yeah,
lately.
it still fits for early or limited stage disease. Yours was a tricky one, and we still struggle with it. Might be a strong word, but we have to figure it out. These stage E's, the stage 2 E's, because if it's disseminated extranodal involvement, it's stage 4. If it's just a lymph node like extending towards the lung, that's more extranodal, but it can be some gray zones and tricky. So radiation still has a role for limited stage, where it's like, especially stage 1, or let's say it was here and here, stage 2. The decision making there is, do I give less chemotherapy and low dose radiation or more chemotherapy? And there's absolutely not a right answer. There's more disease control. It's more effective to receive radiation. The trade off we always debate is, what about some of those late consequences? Can it contribute to that? So it still has a role. Late consequences, sure. And it partly depends on the treatment, but that's whether chemotherapy or radiation. So one is arterial disease. Now it depends on location, but let's say, radiation here to this area. Now, radiation techniques have gotten much better over the years, and that's not even including proton radiation, which is incredibly sculpted to that individual area, even with something called involved site radiation, really 3D small margins. But if there's any scatter of radiation, there could be some carotid involvement. Or if there's radiation in this area, obviously there's cardiac involvement, arterial. It's not like there's incredible risk. It's a little bit increased of the arterial risk, etc. And that's not to say there aren't risk of chemotherapy, by the way. When we've looked at just chemotherapy, there are increased risk of myocardial infarction later in life, because the adriamycin, can rarely, but it still happen, irritate the heart, not just acutely, but later in life. Another secondary or late consequence we think about, unfortunately, can be second cancers. It's hard enough to have one, but sometimes 10, 20, 30 years later, there can be a secondary breast cancer or thyroid, things like that. Those are really more serious late effects. Other still serious, but maybe not life-threatening later late side effects could be things like low thyroid, hypothyroidism, or fatigue, or neuropathy, irritation of the nerves, which can contribute to Brentuximab vedotin from that agent, and others. The V and ABVD can contribute to neuropathy. So at the end of the day, yes, clinical trials are so important, and it's been able to show, how do we get these novel agents approved? How do we bring them to the front line? But then, yes, we also need to study those late consequences.
Absolutely. Can you mention the name of just a couple of those clinical trials with respect to the targeted therapy and the immunotherapy?
Yeah, sure. And many of the ones that garnered its approval for relapse don't have an acronym or a name, because they're often phase 2 trials. We think of you needing phase 3 studies to garner approval, but in uncommon diseases, yes, Hodgkin's is uncommon. It's only about 8,000 patients a year in the United States. There's about 90,000 non-Hodgkin's. So it's hard to have randomized data, and with a really rigorous large phase 2 study, it can garner approval. But there have been a couple, thankfully, phase 3 studies. One of them that garnered approval of Brentuximab vedotin for in the maintenance, meaning after a transplant, was called AETHERA, AETHERA. So that was a phase 3 blinded randomized study. Standard of care for relapsed Hodgkin's is usually therapy, some form of therapy, whether chemotherapy or Brentuximab vedotin, then a transplant. And at the time, that was it. AETHERA added one time a month for a year of maintenance therapy and showed a pretty significant benefit that garnered that approval. But then it was like, well, why do we have to wait for relapse? What about if I do it at the beginning? And the long story short, a really important global study called Echelon-1 that was published and has been republished a couple times in the New England Journal of Medicine, showing when you replace the bleomycin with Brentuximab vedotin, its trade name is Etcetera, so the acronym is ABVD, no bleomycin, was compared to ABVD. And the real landmark breakthrough on that study was not just showing what's called a progression-free survival. There actually was an overall survival benefit, which we had never seen in the field. Part of that is that's always the standard. You, of course, want an overall survival benefit, and some of the updated analyses of Echelon-1 showed that. And so that's great. But we're not done yet. So we said, okay, AAVD, you might be the new king of the hill. How can we knock you off? And the most recent phase 3 randomized trial was actually conducted here in the United States by our cooperative groups. We didn't have an acronym to the study. It's by the cooperative group. It was called SWOG 1826. And although all the groups, including the pediatric oncology group, participated in this study, that's another important point. We're really working together with our pediatric colleagues to go after Hodgkin lymphoma. And that compared nivolumab, one of the checkpoint inhibitors, AVD, to the AAVD. It hasn't been published yet. It's been presented a couple times. And the long story short, at least at 1 year, the checkpoint chemotherapy looked to have a higher progression-free survival than AAVD. So again, as we go through these studies, we're just trying to not only get better, but can we also get better and have less side effects?
Absolutely. That makes a lot of sense to me. Briefly, just for people that are watching, could you explain the difference between progression-free survival versus overall survival and why that's exciting?
Yeah, that's a tricky one. Well, we could spend a little bit of time, but it's important. What progression-free survival basically means is the length of life might not be different. But I'm in remission, I'm progression-free, or in remission longer. In other words, let's say a trial initially, let's say the initial trial when we first looked at Echelon-1, we saw that progression-free survival was improved about 10%. So another way to say that is something like at 3 years for patients treated with AAVD, it was, let's say, around 80% of patients were still in remission versus 70%, or maybe it was 85 and 75. So that's good. I'd rather be in remission longer, but I'd also like to live longer. I'd have to have longer life. That's overall survival. And what I can say is before Echelon-1, there had never been a study showing better, longer overall survival compared with classic ABVD. Part of the reason is because if you have a good second therapy, even though there can be side effects like a transplant, if you didn't have a good second therapy, then it's easier to modulate overall survival. But what they showed when they looked at 6 years for the AAVD, now there was overall survival improvements. And that's really was a game changer in the field. to garner not just, it was already FDA approved based on progression-free survival, but I think it really became more common in use after the overall survival data.
Thank you for that. These are really exciting times, I think. I hope to never need the services of a hematologist ever again. But I do have hope that, heaven forbid I should experience another relapse, that there's treatments out there, good treatments, to provide, remission and quality of life. In particular, another one is pembrolizumab. I've heard that one. And just it's
Yeah,
kind of a mouthful there, but tell us about
Pembro. See,
pembrolizumab.
you see
Pembro,
Pembro and yeah.
Nevo and Pembro. I love it.
So that's another checkpoint inhibitor, and it's much more similar than different. The two between Nivo and Pembro, and there was an acronym to that study. It was a lot of their studies are the keynote studies from that company. What the keynote studies, and it has a number in particular in Hodgkin's was 087. They keep adding numbers throughout all the different cancers, and that was initially approved as Nivo or nivolumab for relapsed Hodgkin lymphoma, and that garnered that approval. That one of the keynote studies, just like nivolumab did. But so that's great. And by the way, the SWOG 1826 was for advanced stage, so stage 3 and 4, because when something gets approved, it's for a certain situation, a certain stage, and certain ages. What about limited stage, early stage? We talked a little bit about chemotherapy, radiation. And for many patients, a common treatment modality for early stage is some patients will receive 6 months of chemotherapy, like yourself. Others might receive 4 cycles of chemotherapy and radiation. And so the question, as we were planning this study for the United States through the US cooperative groups, and this study is involving the pediatric oncology and the adult groups. The children's oncology group is leading it, but we're all working together. And so there is a new study, national high priority study, open as we speak. That acronym is AHOD, AHOD 2131 is the study name. And in real simple terms, it's comparing the standard of care that we just talked about for early stage disease versus everybody on the new arms, on the hopeful arms of just 2 cycles of chemo and the rest targeted, a combination of Brentuximab, vedotin, and checkpoint. And we'll see, the hypothesis is it'll be more effective and likely better tolerated. And that's ongoing. It just opened up earlier, I was going to say earlier this year, but last summer it opened. And so it's planning to enroll over the next couple of years. And what's great about that study is not that it's just incorporating novel therapeutic agents in place of cytotoxic chemotherapy, but we're going to study over 10, 12 years some of those late effects, late consequences. And that's sometimes a gap with clinical trials. They're great in the first couple of years and they fall off. And they just don't have the resources or funding to study late effects. So in great collaboration with the National Cancer Institute and CTEP, they are providing resources to not just study those initial 3, 4, or 5 years, but extending beyond 10 years, which is fantastic.
You just brought up some great points, and I just want to highlight this for patients, because I don't even think I felt empowered to think these things or ask some of these questions initially with the shock of diagnosis. But clinical trials are not just for people who are on death's door or after they have failed multiple lines of therapy and then they're thinking about clinical trials, right? Like clinical trials could be for multiple situations. Like, how do we de-intensify therapy? How do we how do we make different therapeutic decisions? How do we change and start using therapies that were used in a very specific situation, like only for relapse refractory, and now start using those therapies for early stage patients up front? And that's what some of these trials are showing. So how do you, what's some advice you could give to patients?
Well, you brought up a lot of really important points, and I think you said the most important word is advocate. Is be an advocate for yourself or family member for your family member, and because this is your life, and there should, not to minimize it, but yeah, there should be no intimidation or concern of talking to the oncologist. The 99.9% of oncologists obviously want the best for their patient. And sometimes they might not always bring up a clinical trial. The provider, that is, they might not have access, but I would absolutely encourage, to your point about, is a clinical trial right for me? Because you said it, where I wish we had a clinical trial for every condition, because what we're ultimately trying to do for every patient, regardless of age, man or woman, stage, there's always a semi-standard of care. We're always trying to do better, or if not do better, do the same with less side effects. And the only way you can really do that is ultimately in a clinical trial. And so these are very sophisticated studies where we're hopeful. Now, of course, we have to prove it in that clinical trial. And the vast majority of clinical trials are with targeted agents or these immunotherapy agents. So I would just implore the patients and patient family members to, if not self-advocate, reach out to other foundations. Obviously, the patient story is a great information disseminator. Other foundations for patients, the Lymphoma Research Foundation, LRF. Their website is the word lymphoma.org, Leukemia Lymphoma Society, LLS.org. They have inlets and conduits to look at clinical trials, whether for Hodgkin lymphoma, non-Hodgkin lymphoma. And of course, could go online and look through clinicaltrials.gov, and you can type in the condition, and it'll list sites across the country where they're available.
And on that note, if you have any questions regarding how do you look up, how do you navigate through clinical trials, Leukemia Lymphoma Society has a clinical trial support center with free access to experts who can guide through that process.
The best outcomes are usually with the most informed patients, and to know the different options. Because I can tell you, in Hodgkin lymphoma, very, very often, there's not one right way to treat it. There's different options. And there shouldn't be anything scary or wrong with a second opinion, to garner advice. And we're often happy to help, and to sometimes we'll have nothing different to offer, or sometimes it might not even be a clinical trial, but it might be a little nuance on certain dosing or something based on a patient characteristic or comorbidity. We might want to make a certain adjustment a priori to a treatment, just because when that's all you do for 20 years, you've kind of seen it all in every condition, and we're happy to lend any advice we can.
I love that. That was such great advice. Thank you for that. Um, I think one of the things we also wanted to talk about is transplant. Where does transplant fit in all of this? I had a autologous stem cell transplant. It was tough. I mean, I'm so grateful for it. I ended up having a autologous transplant. I had beam therapy as a conditioning regimen because I had hemorrhagic cystitis from cyclophosphamide when I was mobilizing my stem cells. So yeah, I did have a rough
And you had
complication.
almost
I
every
did.
side effect in the
I
book.
did. And then I had pneumonitis from carmustine. So yeah, I mean, I this is separate, but I believe that I had this cancer at this time in my life and had such a tough course, and also in my medical career, so that I could learn about these things and be an advocate and go into longitudinal survivorship, which I could talk about another time. But because I know now some of the questions to ask, what are some of the things that can happen, and how hard it can be, even when it's the good cancer. Which there is no good one, but yeah, so transplant, and then I went on and I did just like a Thera. I had 1 year that I just finished 6 months ago of post transplant Brentux. Um, so yeah, tell us
Did you
about
have
where
any
transplant.
neuropathy? Did you do okay with it?
I did. I had neuropathy. I ended up getting dose reduction because we learned before I had transplant that I needed the dose reduced Brentuximab as well. And so and I was having some neuropathy, which for me, it wasn't just the pain, it was kind of like falls and clumsiness, and I'm dropping things.
It was
And
affecting your function. Yeah,
yeah,
that's
it really was. And I do a lot of
serious.
procedures and stuff. So for people like who work with their hands, or do a lot of things with their hands, with their feet, it could be important. So yeah, I did end up having dose reduction, and then the neuropathy is recovering. So it's still there, but it's recovering. But
Yeah, so transplant has been the standard for over 30 years for Hodgkin lymphoma in younger patients. And when we say younger, less than age 70, believe it or not. to receive some new treatment and then, meaning get back in remission, and then a one-time transplant, which is, when we say transplant, I'm sure it was your own cells, right? Autologous transplant, which is not really a transplant. We do immune system transplant, so-called allogeneic. Rarely do we have to for Hodgkin's. And as you know, what autologous transplant really is it's one cycle of high-dose chemotherapy followed by rescue of your own stem cells back. So you bounce back up after the chemotherapy. And as much of a standard of care as it's been, we're revisiting everything. And what we're starting to ask the question, even though it is a standard, is, does everybody need a transplant? Are there certain patients, especially now that we have Brentuximab vedotin, checkpoint inhibitors, can we lean on these targeted? And so that's a perfect example. And there is not a study that's set up. It's being actively discussed with the National Cancer Institute and many leaders across the country. I'm helping represent ECOG cooperative group as part of this planning, because studies aren't designed in like a few weeks. They take months and sometimes a couple years to plan, because you want to get it right and you want to have the latest treatment, the latest data. So we've been talking about it, planning it now for 6 months. And ultimately, though, to prove it, because it can't just be an idea, we have to prove it, it would have to be a clinical trial where there's some randomization to the standard transplant or no transplant. So I think we need to look at it. It's not done yet, but I'm hopeful that is something we can explore, that we can actually cure relapsed Hodgkin lymphoma without a transplant. But right now, that's not the standard of care. It would be a transplant.
How about continued monitoring? Like, do we monitor patients, or after they've received a certain amount of treatment, do we just say, go on and live your life, and if you develop symptoms, then we'll get a scan? Or how are we monitoring patients in the Hodgkin's lymphoma?
Yeah, good question. And there's different practice styles. And part of the reason, Sam, there's different practice styles is actually, it also kind of comes back to data, because we don't want to just do a scan to do a scan. Is it helpful? Does it tell us information? What had been standard for a while, what we do know is whether initially diagnosed or for a relapsed situation where there's a transplant, if it's going to come back, the vast majority of the time, over 90% of the first 2 years, from diagnosis, we count. So some of us will still, during that 2-year time mark, counting from when the initial diagnosis or the initial relapse, will usually see patients every 3 months in the office, physical exam, history physical, maybe some limited blood test, and sometimes do a scan, a CAT scan every 6 months. Not everyone does scans. They think there's just lead time bias, and maybe it helps you pick up a little bit earlier, but doesn't improve survival. But for sure, if someone does scans, should not do it past the 2-year mark. There's radiation, as you know, with CT scans. We don't think of it, but for many CT scans, that's equal in radiation to 500 chest x-rays. Think of getting 500 chest x-rays. And so it's something we want to use if it's helpful, but not too much. But then the question, what about after 2 years? What about after 5 years, 10 years? That's where I think we need a greater focus and an opportunity on bona fide survivorship clinics. And there are some good, maybe not perfect, algorithms. I know our pediatric oncology group at the Rutgers Cancer Institute, they have a computer program. Well, they'll put in patient age, treatment, radiation, and it will basically generate on best available data. Here's basically your primary care follow-up. You should have an echocardiogram every 5 years starting at age 30. You should have breast cancer screening starting 10 years earlier, cholesterol, etc. And none of these recommendations are lightly. They're usually evidence-based to show that there's some impact on that. So I would say individualized, but it's something that we need to make sure as a community, our patients know that this is still very important, the survivorship aspects. And oh, by the way, it's not even just about breast cancer screening, heart screening, et cetera. What about chronic fatigue? What about anxiety and some other emotional disturbances that can happen? And so usually part of a survivorship clinic like we have at the Rutgers Cancer Institute, you have literal experts, physician experts like yourself, nurses, social workers, et cetera, who are surrounding the patient really throughout the lifelong care continuum.
I love that you made that distinction because of surveillance and survivorship. Because I think surveillance is a big part of survivorship, but it's not all of survivorship. And my understanding, and speaking with people from NCI, Office of Survivorship, is that that's kind of a hot topic within the survivorship research community right now. Is what is a mutually agreed upon definition? It includes surveillance, but it's also like cancer surviving mindsets and how do we plan for a life after hearing the words you have cancer, including oncofertility and social emotional well-being and family planning and sort of reintegration in work life or society or your family. Like, how do you basically live your life after you've had a cancer diagnosis, regardless of your sort of remission status or where you're at and all that, including like make sure that you get your scans and your blood work and all that. But I think a lot of people in the community are starting to realize that it's so much more. And I'm hoping that ultimately it'll be a board certified fellowship in the next, 5 years or so, with core competencies like this is what a survivorship clinician should know and be able to talk to patients about.
Absolutely. And we had talked a little bit about that holistic consortium, and that's one of our goals in that. And despite the uncommonality, as we said, in terms of number of diagnoses, it's remarkable that what we've come together under this consortium and have done in the last few years. And that's really gathered the world's data of clinical trials. So many of those clinical trials we talked about, this is individual patient level data. We obviously have it's de-identified, careful individual patient data, but into a huge master database with a common data model and data dictionary, so it all comes in a readable and harmonized fashion. But that's only one. What we've also knitted together and synthesized this large amounts of clinical trial data. There are survivorship clinics and survivorship cohorts out there across the world. For example, there are some of data, not just patients, but literally collecting data over years and decades at Princess Margaret in Toronto, BC Cancer Vancouver, Stanford in California, in Australia has one, in the Netherlands, Danish colleagues. And we have already put together over the last few years 20,000 cases of patients in clinical trials and survivorship registry cohorts that we're putting together, again, not to tell anyone you should receive this, but to really just give some objective information, not just for early on, but if you did A, B, or C radiation or Brentuximab, here's your expected efficacy and side effects based on your individual characteristics, but then also to simulate as best as we can tell based on this treatment at this point in your cancer journey, here's what we estimate to be your 10, 20, and 30-year late consequences. To basically feedback to make a more personalized survivorship plan, not just an initial treatment plan. And the way we're going to do that is through just large amounts of big data and data analytics and even so a little machine learning mixed in.
That's really exciting to me because one of my big aha moments with starting to participate in the survivorship community is that survivorship is defined as anybody living after a cancer diagnosis, but it doesn't seem to be routinely delivered that way. It seems that it's kind of piecemeal and it's sort of focused on a couple cancers. I really believe that longitudinal survivorship is the way, meaning that we should deliver survivorship from the time of diagnosis, like in parallel with oncology care that's delivered from the oncologist, meaning like if we know we're going to give a person cardiotoxic chemotherapy like adriamycin, let's not wait until they develop heart disease 20 years down the road to start talking about, hey, let's pay attention to heart disease risk. Like maybe we put people through intensive lifestyle medicine therapies where we talk about diet and exercise and metabolic assessment, like making sure everybody gets an A1C and their cholesterol checked and their blood pressure at the beginning and all the way through treatment, and start talking about heart health in the beginning. So I think, I'm excited for that. And
We look forward to, and I'm very serious, is because we have some patient advocates. So I'm going to be sending you an email at some point. We'd love for you to become involved in some degree as a patient advocate and obviously a physician expert in this field as well as part of holistic. We're still gathering data, building data, but we're looking forward to start, well, how do we best apply this to patients and the medical community?
Yeah, that's great. This has been just such an exciting conversation. Um, what are some final takeaway messages that you have for patients, for providers, for advocates?
I think we've talked a lot about it, and informed provider, patients. It really starts there of knowing that, yes, is this treatable, curable? You betcha. Whether it's newly diagnosed, even if it's stage 4, even if it comes back once or twice, but there's different treatment options, and it's good for patient and family to understand there are different treatment options. And when we say different treatment options, meaning, as we've touched upon, how effective is it, but how am I going to tolerate it in the moment and also later in life? To try and early on is start survivorship. Yes, of course, number one is going to be cure this, but cure it and do so with minimal side effects. And it really comes back to personalized cancer care. And what we can say is there's been great progress over the last few decades, and we still have room to get better treatments, better tolerated, better knowledge. And we're just so thankful to have such well informed patients, patient advocates, scientists, clinicians, epidemiologists, survivorship experts, really everyone coming together, laser focused for specifically Hodgkin lymphoma to continue to advance the field.
Yeah, I agree. I think that for me, there's a palpable shift in cancer culture. Like, we need to do more than just focus on not dying. Like, let's focus on the living part. How do we help people not die? That's a huge part of it. But in addition to not dying, how do we help people fully live after facing a cancer diagnosis? So, this is a really exciting time. And I'm just super grateful to have had this conversation with you, and can't thank you enough. Anything else we should add?
I don't think so. I think you've really hit all the points, and I just no, I think we've hit it all.
Awesome. Great. Well, thank you so much for your time.
All right. Thank you so much, Sam, for being such an incredible patient advocate, for all the work you do, in addition to leading the discussion tonight. Also, thank you so much to Dr. Andrew Evans. Dr. Evans, the fact that you spent all this time helping patients and care partners better live life after diagnosis. We really are grateful for you for that. And thanks to all of you for tuning in to this program, co-hosted with the Leukemia and Lymphoma Society and Immerman Angels, with the patient's story. So again, we really want to hear from you. We take what you say, with great care and consideration. So our survey is going to pop up after this program closes to get your feedback. It should, again, just take a couple of minutes. And if for some reason it doesn't work out, we will be sending the link again in a follow-up email. So thank you so much for joining us. We hope this was really helpful for you. We hope to see you again at a future The Patient Story program. I'm Stephanie Trong. Take good care.